Okay, alhamdulillah wa salatu rasulillah. Assalamu alaikum wa rahmatullah. This is Dr. Amber Khan. I am the chair of IMANA Education. Tonight we have another wonderful education awareness talk tonight, and this one is regarding cancer screening awareness. As some of you may know, September brings awareness to several different types of cancers this month, and our committee aims to guide you on the importance of screening and preventive care, as well as early detection of symptoms for more treatment options and better outcomes. Tonight, we are proud to have a panel. It will be led by Dr. Marium Husain, and her and Shifa Mohiuddin. They will be discussing screening, how screening saves lives, and they will also be commemorating Chadwick Boseman, whose recent death brought heightened attention to colorectal cancer. Later on in the talk, we will also have a special presentation by Dr. Darrell M, who will discuss gastroenterology and undertaking frequent and regular colorectal cancer screenings. So just a little bit of information on the speakers before I pass it over to them. Dr. Marium Husain is a hematology and oncology fellow at the Ohio State University James Comprehensive Cancer Center. She graduated from the Ohio State University College of Medicine and completed a residency in internal medicine. She has been working on community service projects in the Columbus area and abroad for the past 12 years. I'm sure many of you know Dr. Husain because she is the Vice President of IMANA. She has been working on public health education and domestic projects as well related to food insecurity, women's health, reproductive health, and climate change. She has also traveled to the IMANA Medical Relief in Haiti to provide primary care at a rural clinic and also help to raise money to bring wells for clean water access. Dr. Husain will be speaking tonight with Shifa Mohiuddin. She is a public health professional who is passionate about her community with medical expertise. She is also the wife of a cancer survivor who has lobbied for the Affordable Care Act and cancer survivorship on Capitol Hill. And more recently, she has been working with the Cancer Fund, which is a nonprofit project in partnership with the Asian American Center of Frederick of Maryland, which is helping to alleviate the financial burdens associated with cancer care for patients and families. She has a degree in Islamic Studies and Biology from George Washington University and a Master's of Public Health in Community-Oriented Primary Care. Alongside Dr. Husain and Shifa will be Dr. Darrell M, who will be speaking on colorectal cancers later on. Dr. Gray is a gastroenterologist and deputy director of the Center for Cancer Health Equity. He's also a member of the Cancer Control Program, where his research is focused on community engagement and preventive health behaviors and interventions, and on understanding the interaction of social determinants of health, public health, and health policy in cancer prevention. Firstly, I would like to thank all of the speakers for coming on tonight. We are very excited and look forward to it. And with that ado, I will go ahead and pass the mic over to Dr. Husain and Shifa. Thank you.
Thank you so much, Dr. Khan. Really appreciate that very kind introduction. I'm just going to share my screen with everyone before I get started. All right, so assalamu alaikum everyone again. Thanks again, Umber, for the introduction. So as Umber had mentioned, Dr. Khan had mentioned that September is an awareness month for multiple cancers, unfortunately. So we don't have a whole lot of time to talk about each of them individually, but we will be having separate talks about them. And our hope today is that we can, inshallah, briefly touch upon them so that you're familiar with it and that you can be aware of some warning signs and what does cancer screening, cancer prevention, being a caregiver, what does all of that mean? So before getting started, you know, as much science as there is, alhamdulillah, and as much as we've been able to do in these last several years, cancer is still a very scary word. And the process to go through it can still be very daunting. And so it's not easy, as Shifa will be able to shine some light on as well too. But one thing that helps keep us through this process and keeps us fighting through this is knowing that even though there may be difficulty, even though there may be difficult times, that as the Quran says, there is relief and that there's also infinite hope, at least from a quote from Martin Luther King Jr. and from the Quran as well. And so that is always in the back of our minds whenever we think about cancer, is that the good and the bad that comes with all of it as well. So just again, a brief outline of what the talk will be for today. So not to get too technical and not to scare anybody with all the sciencey part of it, but basically cancer is one of those things, to bring it down to its very root level, is that it starts with just one cell. That's the way to think about it. And unfortunately, it can really be any cell, but it starts with one. And if you can see my cursor here, is that the main focus area that a lot of treatment and a lot of science is on is this part right here, this initiation area. Is that something happens to the normal cell, and then it starts its process to becoming a cancer cell. And so what we try, and you can see that there are a lot of steps in the process to it becoming a full-blown cancer that we can see on imaging or a biopsy, and when it starts to spread outside throughout the body. And so we are trying to help, science every day is trying to figure out ways that we can stop these cancer cells from going along that process, and try to also understand the factors that cause these problems to happen or cause a cell to become mutated. So that's just trying to put cancer in a very basic understanding of how it starts. Now, unfortunately, cancer can start from any place in particular. And the way that we divide it up to kind of help with diagnosis and treatment is that you have the bone itself and the bone marrow specifically, and then you have all the other solid organs. So when you think traditionally about breast cancer or lung cancer, that's kind of on the right side of the screen, all the organs that you can see. The bone marrow is the factory where all the cells are made. And that's where other cancer cells can develop. And so the bone marrow makes the building blocks of the red blood cells, the white blood cells, and platelets that we all need to function. And basically, again, this is a very busy slide, a very technical slide, but the basic gist is that you have cells at the top here, these stem cells that every bone marrow has. And they basically go through a maturing process, the same way you can think of a baby maturing into an adult. And so we all want adult cells, these cells that fight off infection, these cells that help cause scabs when you get a cut. And so you can see that from top to bottom, that there's a lot of maturing that goes on between these cells and a lot of dividing that happens. And the problem can sometimes happen specifically for bone marrow cancers is that in that maturing process, something goes wrong along the way, along all of these steps to become a mature cell. So what are the different types of bone marrow cancers that you can get? So the first three cancers we'll delve into are leukemia, lymphoma, and multiple myeloma. Now I'm sure many of you have probably heard about some of these cancers already. And so leukemia is something, all of them are thankfully not very common, but they do happen to a lot of, but when you are someone who has that, it can definitely be a life-changing experience. So roughly about a little more than 60,000 people are expected to be diagnosed with leukemia this year alone. And so what is leukemia? So, and the slide that I mentioned previously is that there's different cells that come from the bone marrow. Instead of becoming mature cells, they stop along that growing process and remain immature. So then they don't work as well. And then because they don't work as well, they cause a lot of problems. So some of those problems is that you can actually get low blood cell counts. You can become anemic. Sometimes you can bleed, or you don't have enough platelets or those cells that cause scabs. So then you can bruise very easily. Sometimes because you don't have enough white blood cells that work, you can actually get infections because your body can't fight things off. And sometimes headaches can happen too, depending on if you have too many of these immature cells that can end up in the body. And those immature cells are called blasts, if you ever come across that word. Now, unfortunately, with as where we are in medicine right now, we're still trying to learn how a lot of these cancers happen. And sometimes, from what we know right now, is that they can happen just randomly. That in that long process that I showed you before, that sometimes something goes wrong in the cell when it's dividing, and then a mutation happens. And then that can kind of take the cell down a completely different pathway, a different journey into becoming a cancer cell. Sometimes you can have a family history where if a family member had leukemia, sometimes that gene can get passed down and then increase the risk of developing leukemia. So in terms of treatment, the reason why leukemia, I was saying it obviously can be a very life-changing experience is because treatment, at least initially, can sometimes look like a very, very long hospital stay on the order of weeks. Because the goal is to try to knock out a lot of these cancer cells, and to do that requires very intensive chemotherapy. But once you're done with that, then you can move on to outpatient and then get chemotherapy that way as well too. A lot of exciting research is being done where people can actually, oncologists can actually use pills to treat some of these cancers as well. So alhamdulillah, we're going along that process. It's just that we need, time, and we need more of the science to figure these things out. So something to take away about leukemia is just, again, out of nowhere, seeing a lot of infections, having low blood cell counts, we're seeing a lot of bruising that you wouldn't normally see before, and then just making sure that you are following these symptoms a lot as well. Lymphoma. So also kind of along those same lines of leukemia, about 85,000 new cases are expected this year. The thing about Hodgkin's lymphoma, there's two different ways to classify lymphoma, Hodgkin's or non-Hodgkin's. Hodgkin's lymphoma, if you've ever come across any with that, alhamdulillah, that's actually one of the most curable forms of cancer that we know to date. So if someone does have that, even though treatment can be intensive, the goal is to actually get it cured. Now, the thing I really want everybody to take away from this particular slide is that some of the symptoms that you can get with lymphoma. Now, they're all pretty nonspecific. If you kind of think about it, that you could have a cold and some of these symptoms would happen. But the thing to keep in mind is if you have persistent fevers that are not going away, especially after Tylenol. Night sweats to the point where you're drenching through your shirt at night and you need to replace the shirt. So not just if you wake up, you're feeling a little sweaty, but this is something where it consistently happens night after night, and you have to change your shirt because you're sweating that much. And not menopausal type night sweats either. So I just want to keep that in mind as well. And then weight loss, you can't explain. Sometimes people feel lumps and bumps in their neck, in their groin area, and their armpits. And then sometimes the left side of their belly will hurt because the spleen is pretty big. And then again, as well, you can get some low blood cell counts too. Sometimes viruses like HIV, EBV, EBV, they can actually, a viral infection, those, if you get infected with any of those can actually be risk factors for leading to lymphoma. So something to keep in mind about that as well. The last of the blood cancers we'll talk about, again, the ones that come from the bone marrow, is multiple myeloma. And so not as common as the other two. So expected about 33,000 new cases this year. And this is a problem with a particular type of cell called a plasma cell that comes off of the white blood cells. And so this one, unfortunately, doesn't have too many specific symptoms, unlike lymphoma or leukemia. So you may not even know. And sometimes if it causes enough of a problem, you can get kidney problems, calcium problems, sometimes bone fractures, and then your blood counts can be low as well, sometimes anemia. You may come across a condition called MGUS, where there is a particular protein that some of these plasma cells release. And then it's just a low level that we're able to pick up in the blood. And then that's how we know if somebody, again, also has myeloma or not. The nice thing about myeloma is that sometimes it can be considered a chronic disease. Because there's so many treatment options that people can have, that you can, it's not one of those things where after a couple, we may not have a lot of options. Unfortunately, there is still no cure yet, but alhamdulillah, we do have some really good treatment options available for people. Switching gears a little bit is some of the solid organ cancers that I was mentioning in the previous slide. So the ovaries. So every woman has ovaries unless they've been taken out during a hysterectomy. So this cancer, again, it's not very common either. About 22,000 cases are expected this year. But the reason why I'm glad that there's a month about this cancer is that for women specifically, even though it's not the most common cancer that women will have, depending on the year, it's the 5th or 6th most common cancer that affect women. But out of all the reproductive organs that women have, this is the one that causes the most deaths. And the reason as well too is because, as I mentioned, there's no specific warning sign that you get sometimes with, let's say, lymphoma, for example, or lung cancer or breast cancer that you can feel. The ovaries are very deep down into the pelvis, and so it's hard to feel them on your own. So sometimes what people will get is that they'll get fluid buildup in their belly called ascites, or they'll feel very bloated. And it's not the type of bloated that after you eat, let's say, breads or something. This is, again, something that's consistent. It just doesn't feel right. You might be losing weight. So the very important thing that I would really like people to take away from this slide is that making sure you go see a gynecologist. Not because you may have a problem, but just, again, when you do the actual gynecologic exam that the gynecologist will do, is that during the manual exam, where they actually feel inside the vagina and the uterus, is that they will actually be able to push on the ovaries and see if they feel anything abnormal, because there really is no good screening test yet for ovarian cancer. So it's very, very important for women to make sure they follow up and get regular pelvic exams. Some risk factors for ovarian cancer are obesity. So again, sometimes it can be hard then to do the physical exam because of all of that extra weight. And then very particularly, something very important, that no matter who your family is, whether you talk to them or not, whether you like them or not, knowing family history can be life-saving sometimes. Because there's a particular gene called the BRCA gene or BRCA gene. Usually people associate that with breast cancer, but it can also be associated with ovarian cancer. So women and men, so for breast cancer, it can affect men too, but specifically for ovarian, if women know about this gene mutation, they can actually get a hysterectomy early enough before there's any signs of the cancer to help prevent cancer from growing. Moving on to the men now, so prostate cancer. September also recognizes this as well. This is unfortunately very common among men. A little more than 191,000 new cases are expected this year. Unfortunately, the same type of thing, like with ovarian, there aren't a lot of symptoms that men will necessarily feel. Sometimes there's weird urinary symptoms that you can't explain to an infection, let's say, or some other functional problem that may happen. Sometimes bone pain, where the prostate is at, again, deep in the pelvis. There's the bones, pelvic bones and hip bones are around there. And so it can be easy for those cancer cells to spread sometimes. Unfortunately, again, there's no standard screening test either that's recommended. However, there is a blood test called the PSA, and I'm sure a lot of people have heard of that before. And so the PSA is helpful sometimes when you want to compare it to a previous level, let's say, and you can sometimes track the PSA to see if it's going up, is it staying stable, and that'll help tell you about, the risk of the cancer growing or not. But in and of itself, if men do not have symptoms, they do not necessarily need to get screened. What will be helpful, again, as you might have guessed, is going to see your doctor and staying up to date, telling him or her what are your symptoms that you're having, if there's anything weird going on. And especially if you have a family history as well too, because sometimes prostate cancer can be hereditary too. And the last cancer I'd like to discuss, or that is also recognized this month, are childhood cancers. So again, any cancer that happens in adult can unfortunately happen with children. But one thing that it's not that it's an adult cancer that's just happening in children, is that it has its own biology, it has its own certain characteristics. So they should be treated as, very specific to children and not necessarily thinking about it the same way we treated them in adults. Thankfully, there's a lot of research around childhood cancers. There's a lot of good outcomes too, a lot of cure rates as well. One thing to keep in mind though is that, kids are very resilient and they can get through some really tough treatments, which is great, alhamdulillah. But then as they mature and become adults, to keep in mind that you can still live with some of the long-term complications of that treatment, and then also to be prepared for adult conditions that can sometimes present as a result of treatments that children received when they were younger. So for example, heart disease can happen a lot earlier in kids who went through cancer treatment because of radiation they may have received. So even though you may think of heart disease in your 60s or 70s, it can happen sometimes in the 40s and 50s for some kids, regardless of diet, regardless of diabetes or anything like that. So I hope, inshallah, I know it was really quick, but just a brief overview of some of these cancers. And I'll hand it over to Shifa now.
Assalamu alaikum. Thank you all, and thank you, Dr. Mariam, for that thorough discussion of the medical background of the cancers. Now I want to move in and shift to a more public health perspective in terms of prevention. As we see in this slide, prevention is key. An ounce of prevention is worth a pound of cure, says Benjamin Franklin. The Quranic ayah, يَا أَيُّهَا الَّذِينَ آمَنُوا كُلُوا مِنَ الطَّيِّبَاتِ مَا رَزَقْنَاكُمْ وَاشْكُرُوا لِلَّهِ إِن كُنتُمْ إِيَّاهُ تَعْبُدُونَ. Eat of the good things which we have provided for you. In other words, eat of the halal and the tayyib also. The Quran repeatedly puts forward the example of halal and basically the lawful and the pure foods, which are, considered, for instance, lawfully slaughtered meat, or else the pure foods that are mentioned, such as zaytun and whatnot in the Quran, anar, which is also pomegranate. These things that are cancer preventative foods, and eating a nutritional whole meal from a holistic health perspective. Going on to the next slide with risk factors regarding what actually leads to our body's ability to develop cancers, depending upon your environment, depending upon your genetic or and also environmental factors. Factors that are known to increase the risk of cancer include cigarette smoking, tobacco use, infections such as HPV, HIV, radiation exposure, X-rays, immunosuppressive medicines post-transplant. Factors that may affect the risk of cancer are more lifestyle related, including your diet, as we mentioned, with respect to what you're eating, whether you're eating more unprocessed foods or junk foods, physical activity levels, or you have your obesity, alcohol intake, whether or not you have diabetes, and as mentioned previously, any environmental risk factors. There are many studies that show exposure to certain types of chemicals and their relation. For instance, here in Maryland, the big Fort Detrick Army facility, there's been a study where they linked some of the radiation exposure there to further development in the city of Frederick to cancers. Cancer screening and early detection and treatment. The U.S. Preventive Services Task Force guidelines have certain recommendations for screening at certain time periods, depending upon the cancer that is diagnosed. Screening for cervical and colorectal colon cancers can prevent cancer by finding early lesions so they can be treated or removed before they become cancerous. For cervical cancer, I believe it's the pap test for about every 3 years, and with HPV every 5 years. For colorectal colon cancers greater than 50 years of age, colonoscopy is supposed to be every 10 years, a sigmoidoscopy every 5 years. Screening for breast and lung cancers helps find these diseases also at an early stage when treatment works best. For breast cancer patients, you have your imaging starts around age 45. Annual imaging for lung cancers, age 55 to 80 years for current or former smokers. Activities that promote early detection and treatment of cancer include providing health educational materials and community outreach activities to encourage screening. Many people don't have the basic literacy, health literacy, to even navigate the process. So supporting patient navigators and community health workers to teach them and guide them along the way to remove the barriers to access cancer information, services, and treatment. You'll see this a lot in undocumented or immigrant and refugee patients who don't even know what the expectations are having moved to this country from elsewhere. So having the proper, translators or whatnot to guide them along the way is very critical. Working within health systems also to improve quality of services, ensuring continuity of care during the entire cancer journey for patients is also important. And you'll see this more as we move on to the next slide. Supporting cancer survivors and caregivers. So nearly 15 million cancer survivors live in the United States today. This is taken from the American Cancer Society's webpage. Cancer survivor is a person diagnosed with cancer defined from the time of diagnosis throughout their lifespan. Cancer survivors and their caregivers face physical, emotional, psychosocial, spiritual, and financial challenges as a result of the diagnosis and treatment. So with respect to the definition of the cancer survivor itself, the way that the Public Health Service counts survivorship itself, they count a 5-year survival rate to give you a sense of what percentage of a certain number of cancer patients are living after 5 years since treatment. And I think you can see sort of in this kind of picture on the right hand side, we see the different types of cancers and their percentages by survivorship, just the maths on that. Cancer survivors and their caregivers go through several stages throughout their journey. I myself, as mentioned in my bio, I am the wife of a cancer survivor, a young adult cancer survivor. So for my spouse and I, it was just a few years just into our marriage, and how that played out in terms of being newlyweds, in terms of what he went through, what I went through, what my in-laws went through. It was quite, in some ways, a setback. And it was a huge setback in terms of financial burden of just the hospital costs and the immediate, amount of financial challenges set forth by his cancer care. But moreover, the emotional toll that goes on from being the spouse of somebody who had cancer, and seeing your loved one go through everything along the way. It's hard both on each other, and it makes you understand how you should be grateful for every moment you have with health. Emotionally speaking, of course, I've described to you, but psychosocially speaking also, you feel almost alienated as soon as you're diagnosed with cancer. You don't know who to reach out to. You don't know whether or not to go back to speaking to your friends or letting anybody know about what's going on. You're really just kind of keeping close to your loved ones at that time, your family, friends, and your faith community, just to get through the next several months of unknowns and uncertainties. And from a spiritual perspective, relying on the masjid for Muslim cancer patients, or your church or synagogue or temple, those all having that religious grounding, being able to have the time to pray and spend time thinking of reflecting on your situation, praying for yourself, and then praying as a caregiver for your loved one. Those all build resiliency for both the patient and for the family along the cancer journey. I just wanted to mention that with respect to like Quran and having an imam or whatnot, like those were also, some things alongside your normal allopathic medical treatment and your naturopathic approaches. Having those people who can be aware of that you're in the situation, just having a strong social support network in general, were key elements to having come out of that situation for many patients. Comprehensive cancer control programs address the needs of cancer survivors and their caregivers using methods such as surveillance to routinely assess the needs of cancer survivors. One of the main public health databases for cancer research, the SEER, Surveillance Epidemiology and End Results Program, I had mentioned. Also education programs to help survivors, caregivers, and providers make informed decisions throughout the process and to ensure continuity of care. Patient navigation systems to optimize treatment and care, and finally policies and systems that changes to improve access to end-of-life care, palliative care, and other cancer resources or services. At the time, I believe that I had mentioned that I had spoken after my own spouse's survivorship. I was actually invited to speak on the Hill for, I believe it was related to the ACA Affordable Care Act and cancer survivorship, and having been able to lobby and kind of speak up for the ACA at that time, those were valuable experiences. I believe cancer health policy, it's definitely a step in the right direction, and I hope that now with Joe Biden and the cancer moonshot, those things can continue. Finally, with cancer health disparities, there are huge health disparities in terms of by race and ethnicity, and what kind of result we see with percentages of Black and African American patients who have cancer versus our non-Hispanic whites, Caucasians, almost double the numbers if you see for cancer death rates and mortality for African Americans versus Asian Pacific Islanders. And it's a very sad statistic. And I think we can all kind of reflect on that and work towards policies that better care for individuals regardless of their race, ethnicity, socioeconomic status, or gender. Thank you very much.
Thank you so much, Shifa. Yeah, so a couple of things that we just would like you all to just take away with, as Shifa very eloquently mentioned, just how important prevention is, and about having a healthy diet and exercising. One thing I cannot stress enough is that making sure to talk with your doctor and not necessarily go to other sources of information that may not be as credible. We all know that a lot of, fake news and everything that's out there right now. And it's not like this is a recent phenomenon. There's just a lot of information out there on the internet. And a doctor, thankfully, and a healthcare professional in general is a much more trusted source of this type of information. And as I was mentioning, that being able to have someone who knows your past medical history, who knows how to compare your different symptoms, that will help with a lot of different other types of cancers that may not have good screening options. And then the last thing, just seeking knowledge itself. It's, as Shifa mentioned, that there's a good mix that we can have between allopathic scientific knowledge and then also faith knowledge as well too. And that the two are go hand in hand. They're related. They're not two separate things. And so as we all, for people who ascribe to Islam, that, the first words given to the Prophet, peace be upon him, were ikra, to read. So knowledge is foundational to our religion and our health, as Umber very eloquently talks about too with Islamic health rights, is that it is a trust upon us to take care of ourselves and to do what we can to make sure that we are living healthy lives and that our families are too. So thank you so much for the opportunity. Thank you, Shifa, and we'll give it back to you, Umber.
Thank you so much, Shifa and Dr. Husain. Moving on, we next have Dr. Darrell Gray. Thank you so much for being here today, Dr. Gray. He will be speaking on colorectal cancers and the importance on undertaking frequent and regular colorectal cancer screenings. Thank you so much for being here, Dr. Gray. Please go ahead and take the mic whenever you're ready.
Thank you. I am so honored to be here amongst you. Can you hear me okay? Just want to make sure the mic is all right.
Yes, I can hear you. Thank you.
Okay, perfect. And I want to thank Marium for the invitation. I am truly honored to be with you this evening and to talk about something I'm extremely passionate about, and that is trying to get us closer towards health equity as it pertains to colorectal cancer prevention. And as many of you know, colorectal cancer is a cancer that impacts the digestive tract, particularly the colon and or the rectum. So the colon is an organ that is a part of the large intestine. It is the large intestine, and the most distal or the lowest part of the colon is what's called the rectum. And that's where actually our stool, right before it comes out, that's where the reservoir, where it's housed. The problem is that these can be areas where cancer can form. And cancer really starts out as an abnormal growth of cells that can emerge on the lining of organs such as the colon or the rectum and then grow over time. And unfortunately, what we know is that albeit colorectal cancer is largely preventable and is preventable with screening, and I'll talk about that, but it is the second leading cause of cancer-related death in the United States. And it doesn't have to be. And this is amongst men and women. There are approximately 150,000 people, men and women, who are diagnosed with colorectal cancer each year. And about a third of those, so close to 50,000 people, die each year from this disease. And again, it is largely preventable. And on average, there's a 5% lifetime risk for development of colorectal cancer amongst the average risk individuals. Now, certainly, and we'll talk about this, there are those who are at increased risk for development of colorectal cancer. Now, there are a few things I'd like to highlight as it pertains to colorectal cancer and just kind of running the numbers. And I heard some from the prior lecturer in regards to statistics. And particularly as we know, and as was mentioned, African Americans have the highest colorectal cancer incidence, means number of new cases, and they also have the highest death rates each year. Now, we have made great strides over time, over decades, in lowering the rates of cancer deaths and lowering the number of new cases. But unfortunately, what has persisted is the disparity, the racial ethnic disparity between Blacks and other Black and Indigenous people of color as compared to white individuals. And there's numerous factors that play a role in it. It's not strictly just race, But there are other factors that play a role in that as well, as we think about income, educational attainment, access to healthcare, just to name a few that play a role in that. But we do know that those rates, as far as death rates and new cases, have persisted over time, unfortunately. When we talk about colorectal cancer, it is not a death sentence. I'll say that again, it's not a death sentence. If you have colorectal cancer that is detected, and particularly if it's detected early, it can be cured. So greater than 90% of colorectal cancers that are caught early, in the early stages, can be cured, okay? And so that's something that's extremely important to share with family and friends as well, because sometimes, you know, just saying the C word, cancer, is that kind of people sometimes will turn off. They won't even listen. Because they're concerned that maybe even talking about it can cause them to have cancer. There are other myths that if someone talks to someone who has cancer, they'll catch it, and that's a myth. Or if they get screened for colorectal cancer or any other kind of cancer, they'll catch the cancer. That is a myth as well. What we know is that screening matters. Okay, so when we talk about colorectal cancer screening, one of the reasons that we've made such progress over the past decades is not, the largest reason is not because we've had new and innovative treatments. Certainly we've made strides in chemotherapies and surgeries and techniques, but that's not the biggest reason. Certainly we've also learned a lot about diet and lifestyle behaviors that we can modify, but certainly that's not the biggest reason we've seen the decrease. The single biggest reason that we've seen the decrease in deaths and number of cases from cancer has been screening. And screening, what that means, particularly as it pertains to colorectal cancer, is that what we're trying to do is to interrupt the cycle or the development from a polyp, which is a tiny growth that can emerge in the lining of the colon, ultimately to a cancer. And so by getting screened, hopefully we're getting at the stage where it's a polyp and we can just remove it. But if in fact we find an early stage cancer, we've detected it early enough that it can be cured, okay? Now, when I also talk about screening, there are multiple methods, and it's really important that you talk to your healthcare provider about methods that are available for you and what might be the best choice for you. Certainly, there are stool-based tests. When I say stool-based tests, it's actually where they test the stool, and depending on which test you get, it can be testing for blood in the stool, or it can be testing for blood and abnormal DNA in the stool. So as we think about tests like a FIT test, FIT, which stands for fecal immunochemical testing, it really tests for blood in the stool. And blood can be a signal that you have a cancer that is very slowly leaking small amounts of blood that can be detected in the stool. There's another stool-based test called FIT DNA. The more common name, or a name that's been branded, is Cologuard. And that's a test, and both of these can be done in the comforts of your home. But that's a stool-based test that looks for both blood and abnormal DNA in the stool. And both can detect polyps, but they are not designed to detect really polyps. It's mostly a cancer detection test, meaning they're not as good as, for example, at colonoscopy in detecting small polyps, okay? There's other tests as well. We think about things like CT colonography. It's like a CT scan. We also call it a virtual colonoscopy. You still have to take a bowel prep, meaning a prep that allows to cleanse your body of the stool that may be in your colon. And then they use a CT scanner to look for things like little polyps or even a mass that could be in there. Now, what's similar between both the CT scan or the CT colonography and the stool-based tests is that if an abnormality is found with any of those, then the next step would be that you have to get a colonoscopy to find out why that test was abnormal, to either diagnose or to remove a polyp or potentially biopsy a cancer. Now that leads me down to another road, which is to talk about what is a colonoscopy. So a colonoscopy is a direct visualization test where I, as a gastroenterologist, can look inside the entire length of the colon and identify and even remove precancerous polyps if I find them. Now, what people can expect before they come in for a colonoscopy, in general, they'll be prescribed a bowel preparation. Again, that's something to cleanse out the colon so that Gastroenterologists like myself, when I go in to look at the colon, there's no stool that's in the way. I can see the smooth colon and identify any abnormalities, no matter how small they are. So after you take the bowel prep, which most people will say is the most challenging part of the process for completing a colonoscopy, and usually that starts, nowadays we do it as a split prep, which means that you have half of the prep the day before your procedure is scheduled to take place. And during that day as well, you're usually on a clear liquid diet, meaning typically no solid foods. And then the morning of your procedure, you're finishing that second half of the prep. And then you have a companion or someone who goes with you and that's important because you're given medicine during the procedure that sedates you so that you are very comfortable and often unaware of what's going on while you're getting the colonoscopy. Now, the time for completing a colonoscopy can vary because based on what is found, polyps or no polyps, or just, how difficult or easy it is to get around, navigate the colon during the procedure. I'd say on average, me doing a colonoscopy is around probably close to 20 minutes, 15 to 20 minutes. And that's because when we're withdrawing the colonoscope, that's when we really spend the most time inspecting the lining of the colon, looking for any abnormalities, looking for any small polyps that can hide behind the folds in the colon. Now, if during your colonoscopy an abnormality is found, such as a polyp, we would remove that polyp again. We send to a pathologist. That's a specific type of doctor who looks at the polyp under the microscope and can tell us whether it is a benign polyp, meaning this polyp had no chance of turning to cancer, or a precancerous polyp, which means over time this very well could have turned into a colon cancer. And based on that pathology, we as the gastroenterologists can then give recommendations on when you need your follow-up exam. So if you have a colonoscopy and you're an average risk individual, meaning you do not have a family history, particularly a first-degree relative who's been diagnosed with colon or rectal cancer, and your colonoscopy is normal, then you wouldn't have to come back for another 10 years. And in fact, so there's several, and I'll go into when you should start screening, but in general, for average risk individuals, it'd be 10 years. Now, depending on if you do have polyps that are found, particularly if they are precancerous polyps, depending on the number of polyps there are and the size of the polyps, that will dictate how short your interval is, maybe 3 years, maybe even 5 years, depending on what's found. But again, that will be based on the pathology of the polyp that is found. That may be different. That should be different, actually. If you have a first-degree relative, a mom, dad, brother, sister, who is diagnosed with colon or rectal cancer, you'll likely be, even if it's normal, even if the colonoscopy is normal, you will likely be on an every 5-year plan. Now, where it gets a little tricky is at what age people should start getting screened. Traditionally, the traditional thought was that people should start at age 50. Again, men and women start at age 50, particularly if you're average risk, and go to about age 75. Now, sometimes you can do a colonoscopy, particularly for screening purposes, after age 75, but usually at the latest, 85 is the cutoff, generally stopping at age 75, however. Now, it's important to talk to your doctor and your gastroenterologist if you get a colonoscopy about what age you might be expecting, because you may come in and say, doc, my mom and dad, they live to be 110, right? So if you're expecting to have a very long life expectancy and you're in overall good health, you may be able to extend how long it is between you when you actually need to stop getting your colonoscopy. You may be able to extend that period. Now, more recently, and I'll say this, particularly in 2008 and then again in 2017 for African Americans, particularly a group in which cancer tends to present earlier in age and at a later stage, it's been recommended by the American College of Gastroenterology and the United States Multi-Society Task Force that it start at age 45. Now, unfortunately, not all insurers have jumped on the bandwagon and covered that. But in general, particularly with patients I'm recommending that for, I have not had any problems with insurers. And if I were to occur that, I will present the insurer on a peer-to-peer basis with the guidelines. Now, of note, in 2018, I believe it was May of 2018 actually, or 2019, within the past year and a half, the American Cancer Society issued a recommendation that all average risk individuals start at age 45. And so now again, insurers don't really cover, well, there are not many insurers at least that cover for age 45 for all individuals. But that's something to keep in mind that particularly as the United States Preventive Services Task Force, which is the main task force where insurers get their guidance from, they will be revisiting their guidelines of starting at age 50 very soon, and perhaps may lower the age to coincide with that which the American Cancer Society recommends, in which case insurers would surely follow with covering colonoscopy at the earlier age. Now, what are some signs or symptoms of colon cancer that maybe you should be on the lookout for? Well, first, I'll tell you there's a caveat, and that is most early stage colorectal cancers do not present with symptoms or signs, meaning you can have an early stage cancer and not even know it. And that's what makes screening so important. You can be a marathon runner, you can eat healthy, you cannot have a family history and still develop polyps or still ultimately develop colorectal cancer. And that's why screening is so important, getting it when you are age eligible and appropriate for getting colorectal cancer screening. But signs could include having blood in the stool. And don't just assume seeing blood in the stool is due to hemorrhoids. It's important to seek a medical professional opinion or evaluation. Experiencing abdominal pain, particularly that's chronic and not tied to anything else. Change in your stools, particularly change in the stool caliber. Maybe you had regular stool and all of a sudden it's pencil thin. Unintentional weight loss, that's another thing. Losing weight, not meaning to, or not intentionally doing it via your diet or exercise. Anemia, meaning lower than normal blood counts. That too can be a sign that there is a cancer. And I encourage you to talk with your healthcare professional about all of those things, should you experience any of them. Now, what are ways in which you can reduce your risk for developing polyps and colorectal cancer? Well, certainly there are things that we can do. We can't necessarily modify our age, right? We can't modify the family we're born into if our family has had colorectal cancer, but we can modify lifestyle and diet. So particularly as we talk about lifestyle, if you are smoking, try to stop. I know it's easier said than done for sure. It's a hard habit to break, but smoking not only puts you at risk for colorectal cancer, but other cancers such as lung as well. The other thing is, if you consume alcohol, we encourage people to limit that, if at all, to consuming alcohol. Thinking about things like diet and exercise. Certainly exercising reduces your risk of colorectal cancer as well as other cancers. And it's just good for heart health. So we recommend people try to get at least 150 minutes of exercise per week. Additionally, as we think about a diet, things that can increase your risk of colorectal cancer are high consumptions of red meat, processed foods. So trying to eliminate those from the diet can reduce your risk. Increasing the fiber or the fruits and veggies in your diet can also reduce your risk for development of colorectal cancer. But again, I want to encourage, as we think about diet, we think about lifestyle, but certainly screening is such an important component. Now, to hit on those who may be at increased risk, there's certain diseases and medical histories that can put you at increased risk. So we think about things like inflammatory bowel disease. That's a chronic inflammation of the colon that can occur in Crohn's disease or ulcerative colitis that can increase your risk. Diabetes can increase your risk of colorectal cancer, and certainly having a family history, whether it's a familial syndrome such as FAP or familial adenomatous polyposis or Lynch syndrome, or just a family history of colon or rectal cancer can increase your risk of getting it. Now, if you have a first-degree relative, a mom, dad, brother, sister who has been diagnosed with colon cancer previously, we recommend that you start early. So you start at either, and this is where it gets really detail-oriented, you start at either age 40 or 10 years younger than the age at which that individual was diagnosed. Okay, so let's put this into perspective. if you had a family member who was diagnosed at age 43, you would actually start at age 33. So not 40, you would start 10 years younger than the age at which that family member was diagnosed, whichever comes first. And so since that family member was diagnosed at 43, you would start at 33. So those are just some of the basics around colorectal cancer prevention, particularly as we talk about screening and diet, when you should start getting screened, and also for those who may be at increased risk when they should start getting screened. But now I want to open it up if Marium or any others have any questions.
Thank you so much for your presentation, Dr. Gray. We have a couple of questions. We're also on Facebook Live as well.
Sure.
One of the questions is, you mentioned several screenings for colorectal cancer. Which screening would you say would be the best? You mentioned that some of the ones that do stool exams don't detect polyps. Does that mean that they would not be adequate? What would be your intake on that if someone was choosing to opt out of a colonoscopy and choosing the former? Would you think that would be a good idea, especially if they have a family history?
Yeah, well, if you have a family history especially, I would recommend colonoscopy, hands down. If you are average risk, I think the stool-based testing is a good option, again, with the knowledge that it's best at detecting cancer. And that can be a good thing because it can detect a cancer at an early stage. But it won't necessarily let you know that there was a small polyp there that ultimately needed to be removed. And so really the colonoscopy gives us the best opportunity to look at the entire colon and find even the smallest of polyps to remove. But that is not to say that the stool-based testing is not a good test. They can be very good. Again, they're very helpful at identifying cancer, particularly early stage cancer. And so that's important. But I appreciate the question because it's important that you explore your options and even ask your doctor about what may be the best option for you. So I appreciate that. Thank you for the question.
Yeah, I think some of the concerns people have with colonoscopy is just the personal discomfort of the exam itself, which kind of leads into the second question here, which is, what advice can you give someone who is diagnosed with late stage colon cancer and they had refused their colonoscopy screening and they're feeling regretful of that decision?
Well, to address the first part of the first statement you made, I understand where the concern can come from around discomfort for the procedure, but I'll tell you, the overwhelming majority, and it's rare when it happens otherwise, but the overwhelming majority of people wake up and wonder if I even started the colonoscopy. And I'm like, yes, I'm all done. You're just waking up from the procedure, meaning people don't feel it. They're not alert of what's going on, and they wake up in the post-endoscopy bay feeling great. So, typically there is no discomfort with the exam. But as it pertains to those who are diagnosed at a late stage and feeling regretful, I think, the biggest thing, the most important thing that I think a person in that situation can do is just, share with family and particularly take the opportunity to share your history with your family members, because then they can use that as empowerment and hopefully encouragement for them to get screened, because they may be hesitant otherwise to get screened, and then you sharing your story will potentially save their life or prevent them from getting a cancer. So that's what's extremely important. And I think just being mindful that even when it's caught at a late stage, there are things that we can do to ensure that you have great quality of life. And I don't know the particular situation, what stage, and if there was metastasis, et cetera, but certainly even in a late stage, there are some treatments. So it's important that you talk to your doctor about what are your options, even with the late stage.
That's really good advice. I think even having your own personal experience and sharing it with your family so that way it is protective of them is something which will be highly motivating for others to get screened. Thank you so much for that.
Oh, yeah.
We have one last question in regards to colorectal cancer, and that is that you mentioned certain foods that increase your risk. What about spicy foods or caffeine or sodas? And also, aside from food, is having a history of H. pylori. Do any of those things increase your risk?
Great questions. All of these are wonderful questions. So no, there is no data that suggests that eating spicy foods or increased consumption of caffeine leads to colorectal cancer. So I'm sure some people are jumping in joy for that they can continue to have their coffee on a regular basis as well. But no, there is no data that suggests that. Now, H. pylori, for those who are listening but don't necessarily know what that is a common stomach bacteria. And that stomach bacteria can lead to things like stomach ulcers. And in some individuals, if it's there long enough, and we see this more so in Asia, in other countries, but development of gastric cancer, so cancer of the stomach from H. pylori. But we do not really see colorectal cancer from H. pylori.
Thank you. And one last question before we close, and this has associated cultural stigmas to it, is certain cancers and being linked with sexually transmitted diseases. Is there any connection between having ovarian cancer or prostate cancer, for example, or even colon cancer, and having had a history of an STD?
Well, yes and no. And I'll say it specifically because particularly what can happen for those, and I don't want to, get too graphic, but so HPV, or human papillomavirus, can be transmitted sexually, and depending on the type of sexual activity that has occurred, HPV can be embedded into the rectum, and people can develop an anal cancer or a rectal cancer because of that. So that is, as it pertains to rectal cancer, yes, it can be associated with sexually transmitted disease.
Gotcha. Okay, thank you. Dr. Husain, if you are still present with us, we had one last question in regards to, and Dr. Gray and Shifa, you're welcome to answer as well. This is in regards to certain genes and having a higher risk of cancer if they are present, such as the BRCA gene. Is it possible for women to request being tested for a BRCA gene if they don't know if they have it within them?
Yeah, that's a great question. So that's why it's really important to make sure that you always follow up with your primary care physician, at least, because they can do a very detailed family history to figure out if you're going to be at an increased risk to potentially have this BRCA gene. And sometimes if you don't have if your primary care necessarily can't do it, but you do have some sort of a strong family history of, let's say, breast cancers or certain types of cancers, you can be referred to a genetic counselor who can do a little more of that in-depth cancer screening. So there are definitely options. As Dr. Gray had mentioned, that sometimes insurance companies can put up a fight about things, but if you have enough of a reason and there's enough documentation to say that you are at an increased risk based on a particular gene or to be able to find one, then those testing options are available for that. And then just a real quick point to the last question about sexually transmitted infections and ovarian or prostate cancer. To my knowledge, at this point, there is no association between an STD or STI and ovarian cancer or prostate cancer, but I think there definitely is a relationship with cervical cancer for HPV that Dr. Gray had mentioned. And there is a condition, prostatitis, so people who have had inflammation or infections of their prostate. There hasn't been a lot of data saying one way or the other either, that's 100% going to lead to prostate cancer, for example. But it's just one of those things that trying to incorporate more of healthy choices, right? Healthier lifestyles, protection during those sexual encounters, that, in general, that just helps your overall health if you ever do have to face something like cancer. I'll give it over to Dr. Gray and Shifa if there's anything else, at least to the first question.
I have nothing to add to that. That's great.
Well, thank you so much to all of you, Dr. Husain, Dr. Gray, and Shifa. We really appreciate you taking the time and sharing your expertise. We would love to have you in the future to discuss similar topics if you are available. Thank you to the public for listening. This session is being recorded and it will be posted on IMANA Education for you to share to your colleagues and the general public as well. Thank you all and have a good evening, and we will see you next time on our IMANA Education webinar. Assalamu alaikum. Thank you again.